Director General is here, so it's the start of the last day of the 5-day marathon. It's been an inspiring meeting so far. But before we start the morning session, I would like to thank the Director General on behalf of all of us for graciously attending this meeting twice during the week. We recognize how busy he is, but his participation is a testimony that he has interest in our area of work on neglected tropical diseases. Some of you have seen him on TV, online, many times. But to see him in person, I think it's going to be a lifetime experience for all of you. I hope that it will also be inspiration and motivation for all of us to continue to work hard to reduce the suffering of people who are affected by neglected tropical diseases and other diseases as well. Some of you, this is the first time in Geneva, and this is the first time in WHO headquarters, and this is also, and to many of us, this is the first time in this beautiful room. We cannot be more than happy and thankful to the organization for making this auditorium available for our meeting. I hope that at the end of the meeting today, whatever lessons we have learned, we will carry them forward into practical implementation. Once again, we would like to thank you, sir, for being here with us. Now, as per the program, since the DG is traveling today, we have readjusted the plan for us to present some of the key highlights of the meeting, and then after that, we will go to the keynote presentation on operational research. So may I now call on Professor Rod Hay to present the keynote. Thank you. The summary, yes.
Thank you, Kingsley. Can I start by echoing on behalf of everyone here our profound thanks to the Director General for his enthusiastic support for this really true new initiative. And through him, we would also like to thank your colleagues in the Department for Neglected Tropical Diseases, because without their tireless effort, this would not have been possible, and we all appreciate that. So I've been asked to provide some general summaries of what we've learnt in this meeting. And it took place to discuss, it's the first meeting to discuss the neglected tropical diseases of the skin, which are all diseases that affect the poorest of the poor, but they all have in common the feature they present with something that is visible on the skin surface. So amongst these core themes are the fact that, firstly, the way to succeed is that these have to be led by countries and owned by countries and owned by the populations who live in those countries. Like all our endeavours, at the heart of all this is the patient, because these are people who've been neglected, they suffer disability, stigma, and mental health disorders. And at this meeting, we've been privileged to hear from both patients and their representatives explaining the problems on their behalf. The reason why the skin has been selected, and I say this not just because I'm a dermatologist, but that's part of it, is the fact that something that's visible is a clear entry point for the strategies related for delivering the NTD roadmap. And we've also heard some very powerful advocacy for both assistance and resources to aid the NTD program. I'd like to broaden it and say, actually, this involves other initiatives of this great enterprise, the World Health Organization. For instance, we've heard how neglected tropical disease is affecting the skin interface with some of the other initiatives that are important to the World Health Organization. For instance, chronic disease. The patient who's incapacitated by diabetic foot shares so much in common by the patient whose life is destroyed by leprosy affecting the feet. The patient with lymphedema from cancer also shares much in common, and their management shares so much in common with those with lymphatic filariasis and those with podoconiosis. And I could give you other examples of this amongst the chronic diseases. Your organization also specifically focuses on the health of the shameful burden of disabled, displaced and marginalized populations with which the world is confronted. And I have to tell you that these populations also have neglected tropical diseases. If you visit refugee camps, you will see patients riddled with scabies, with cutaneous leishmaniasis, and with mycetoma. And these need to be addressed. And the environmental threats to our planet, again, which the World Health Organization is taking a lead on, are also interplay with problems in the skin. So solar radiation and the global epidemic of skin cancer, and particularly in marginalized populations, those with albinism, who are desperately susceptible to life-threatening skin cancer, are also threats. We've also heard about critical shortages in our capacity to deal with these diseases. One of the most shocking statistics that was produced yesterday was in relation to laboratory diagnosis. We heard that 3% of the resources devoted to health go into this critical area, and yet the wastage of money due to misdiagnosis is astronomical, and just simply improving laboratory diagnostics would address this. We also need new drugs. Some areas, such as mycetoma, leishmaniasis, desperately short of new drugs, and we need those. And it also interfaces with the rise of antimicrobial resistance. So we heard of simple examples like resistant staphylococci in children with tungiasis in Kenya. We've heard about the spread of an epidemic of drug-resistant ringworm coming from the Indian subcontinent and now spreading into the Middle East and Europe and probably Africa. We've heard about inspiring examples of health system adjustments and learning processes. These need to be strengthened further. And if I were to single out one thing, I would say that here is a wonderful opportunity, which was highlighted by our presenters, of training, particularly frontline healthcare workers. And finally, we need ammunition to make our case. We have too little information on the impact of neglected tropical diseases, both on the economics, the macroeconomics of nations, but also on the microeconomics of the burden on individual family budgets. Too often, we've heard of patients presented here who've defaulted from treatment from leishmaniasis or mycetoma, for instance, simply because they could not afford the drug. So, what do we need? You expected I'd come around to this, but I hope that much of this is actually very simple. The first thing, we need advocacy and your support in helping deliver this advocacy, and we can guarantee in this group here that we will do our utmost to try and make the neglected tropical diseases the focus of people's attention. So, examples where this could be really useful is in initiatives involving other great health architectural discussions. And They may be, for instance, universal health coverage. They may be in preparing for the next, alas, pandemic, for health emergencies, and for addressing climate change. And these are simple issues. It's about use of media, it's about talking, it's about communication. The other thing is to always think of NTDs in when other critical global policies are being developed and discussed, whether, again, they're around health emergency planning, universal health coverage, One Health, or primary health care. And I'd like to re-emphasize that, as we learned yesterday, that frontline health workers are absolutely critical to our endeavors around this room. So, are there more specific mechanisms? Well, if the NTDs could get access for inclusion into the Global Fund, that would make an enormous difference. And also to try and advocate for support through other sustainable funding mechanisms, going directly to countries who are suffering from neglected tropical diseases. Coming closer to home, it would be of enormous benefit if the programs had access to more local funding mechanisms through, for instance, the WHO flexible funding, and also access to more specific initiatives such as the Global Health Emergency Appeal. So these are our asks, and some of them are simple, some less so, but we mean this most sincerely in seeking your support. I would like to end by just simply giving you an Irish saying, which is very appropriate in this morning, which is, may the rain fall softly upon your shoulders until we meet again. Thank you.
DG, you have my permission, at least today, to speak.
So Chair was expecting me to speak, so I said I cannot speak without the permission of the Chair. I now have the permission, so I'm glad to be here with you, but I will start with apologies. I was supposed to travel in the afternoon, and that's why I wanted to join you at the closing and listen to your the summary of your deliberations and also the recommendations and the asks from me. But then we're traveling to Italy, Ancona region, and I will tell you why. Flights or other travel means, I think, will not get us there unless we leave by 11 or 12. So that's why we had to change our program. And the reason we're traveling there is, I think it would be good if you know, as you remember, in 2003, there was an epidemic of SARS. That's the first SARS. And Dr. Carlo Urbani, the late Carlo Urbani, who was a WHO staff working in Vietnam, played a very instrumental role in diagnosing the new disease, the SARS. And he even had a chance to treat the first few cases and helping the government also on public health measures. But a few weeks after he contributed to the identification of this, the SARS, the outbreak then, he succumbed to the disease. And it's already 20 years since he died, since he passed away. And I think you can see the best of WHO in him, in Carlo Urbani, because he gave his life while saving others. And his family and friends have built a museum in Ancona, where he comes from, in that region, and it will be inaugurated tomorrow. And it would be very important, actually, that I join in order to pay tribute, because he is, of course, one of our staff who has given his life while serving others, and to be honest, something that the world should really know what it means to work for WHO. As you may know, we lost also 2 colleagues in DRC, North Kivu, who were killed by armed groups in cold blood during the outbreak of Ebola in DRC, North Kivu, from 2018 to around 2020. Of course, we managed to contain it, but it needed 2 years of work. But at the same time, we lost 2 of our colleagues also in DRC. So that's why I will be away to really pay tribute and show our respect to our late colleague, who is a model for all of us. So that's why. And then to NTDs. As soon as I graduated, by the way, I started my professional work with NTDs. And I used to work on schistosomiasis. As you know, Schistosoma mansona is very prevalent in Ethiopia, almost all over the country, while Schistosomia hematobium is a problem in the Afar region mainly. And I started with schistosomiasis, so I know about NTDs from early days, actually, how neglected they are. And as Professor said, they affect the poorest of the poor. But not only schistosomiasis, we used to work also, since it was on the same program, on trypanosomiasis, leishmaniasis, and the rest. So maybe as soon as I graduated, the first exposure was actually NTDs. Then, of course, I moved into malaria, which is related. Most of our NTDs are vector-borne, so a good number of them. The malaria experience also is related to the NTDs. They're almost, they can be put in the same category, except the NTDs are neglected while malaria has some attention. So I just wanted to share with you that and the reason I really appreciate what you're doing and also agree with you that we should give it our attention is because I have the first-hand experience of what it means. Then, thank you, Professor, for the presentation. I mean, the outline of the presentation and the summary that you have shared with me are very, very crucial. I fully agree with all the recommendations you have said, and the asks, of course, as well. I don't want to go into details and comment one by one, but maybe to say just a few. First of all, the first thing I saw, which I really appreciated, is the country leadership and country ownership is crucial. Unless countries prioritize it, it will be very difficult to get result. So from my own experience at country level, the differences between the success in one program and not the other is based on the level of ownership or the political commitment you have at the country level. So I think underlining that is very important. Of course, many of our countries need support, but at the same time, I fully know that any country can also contribute its share, can put its share on the table, for anything, by the way. How small it is, it doesn't matter. It shows commitment, even if it's a very small contribution. What matters is the commitment. But that commitment should lead into putting or allocating also local resources, whatever the amount is, based on what the country can afford. That, I think, is the start of any successful program, and I'm really glad you highlighted that. And then, of course, as you rightly said, it should be patient-centered, and I'm really glad that you have participants, patients or their representatives, which is very, very crucial. We're making better progress in the preparation of our guidelines, the norms and standards, by involving patients, by involving people who experience the disease. And the guidelines we prepare without the involvement of the patients and with the involvement of patients are entirely different, actually. Those we prepare with involvement of the patient, for instance, I can tell you a very good example, and very successful one is tuberculosis. The guidelines now that were prepared with the support of patients and their representatives is very practical, something that can help the patients. So on NTDs, I think we should do the same, and I think that's what you're saying, but involvement of patients and people affected or communities should start from even preparing the guidelines, and as well as the control, elimination, or eradication programs that we have. I don't think there will be a program that will succeed without the involvement of the communities, but it should be throughout the whole process and end to end. They know better than we do. Then, of course, on advocacy for resources, as you know, the countries affected by NTDs are very low-income countries. They need support, and the advocacy and mobilizing of resources to support them is crucial, which you have underlined. Of course, I said any country can put something, however small it is, can contribute, but I think most of the countries we're talking about need big support in terms of resources. And as you know, all the things we do, starting from lab diagnosis, from the diagnosis, the treatment, rehabilitation, it's costly, and which cannot be really covered by any of the countries that are really affected by these diseases. And then the other is the cross-cutting, you said. It's a cross-cutting, so meaning if it's a cross-cutting, then means integrated services, which is also in the framework. I think that's central, and I fully agree. And the advocacy and visibility should also be attached with universal health coverage, which is correct, by the way. If we're going to say universal health coverage, then we cannot have universal health coverage by neglecting the neglected tropical diseases. So mainstreaming them in our UHC, PHC, in other programs will be very important, including in policy, global policy documentation, and so on that you have already proposed. On Global Fund, I used to chair Global Fund from 2009 to 2011. There was a discussion, I remember, on including this. And I remember this and also maternal and child health. I think this is, to be honest, late And if we, see the conditions or the situation at the country level and the support that they need, I am with you, and I would be happy to talk to Global Fund on the inclusion. And it makes sense also, because of some methods we use the same as malaria, actually, which is one of the focus for Global Fund. But I think including the neglected tropical diseases will be very, very important because of the cross-cutting issues, but at the same time, since this affects the poorest countries, and financial support is important, especially if it's included in mechanisms like Global Fund. As you rightly said, it means there would be some sustainability of the financing as well. Then, of course, there is the last ask you have made is on flexible funding to our program in WHO. You said homecoming. As you know, some decades ago, the funding for WHO by and large was from assessed contribution. Actually, more than 80% of our budget was from assessed contribution, while less than 20% was from voluntary contribution, this earmarked contribution. Over the years, that has shifted to exact opposite, actually. Now we have less than 20% assessed contribution, while more than 80% earmarked, non-predictable, non-flexible funding. So NTD is being affected like other programs. And we have been asking our member states to change this situation, because if it's more than 80% voluntary contribution and earmarked with strings attached, it means it's not about money. It's actually compromised WHO's independence as well, because there's many strings that are pulled from different places. So our argument to our member states was, it's not about the amount of money, it's about the independence of WHO, and we need to move. And the member states have already agreed to increase our assessed contribution from its current to 50% of our budget, which is going to be significant, but it will take time. This is going to be happening over 7 years through installments, because countries also have problems in their budget. And the second is replenishment, similar model to the Global Fund in Gavi. And these are as part of the sustainable financing for WHO, as part of the reform, the transformation we have been doing in WHO. Because one of the systemic problems is in the financing of WHO. So we have this good news, and as part of that, I think entities will get its share from the assessed contribution and also from the replenishment model that we're pushing ahead. So thank you so much again. Not only as Director General, but count me in as one of you, because my experience actually starts with neglected tropical diseases, and I know what it means. When I retire, actually, I can work on malaria, I can work on NTDs. And we'll do back and do cats met. Anyway, I will follow up on the asks and make sure that we make progress. I don't want all your efforts the last 5 days will be wasted. We'll make sure that your recommendations and advice is implemented. And we hear you clearly, and I think it's now going forward time to make sure that your advice and recommendations are implemented. And we will work with SOSE. SOSE, as you know, has very, he's a very seasoned expert in NTDs. He led eradication of guinea worm in his country, in Senegal, and of course other experience, so he knows what he's doing. you have really excellent leadership in him, and I will give him all the support. He has the experience and also the experience not only in entities but in the others. You said we need to integrate malaria, he's a malaria expert, and in emergencies, and also in health systems, and as a WR also, country representative, which gave him experience of almost all that what WHO does at country level. So he has advantage now to really bring NTD into, based on what you suggested, whether it's UHC or emergency or climate, I think he can do that, and I will give all the support that he and his team needs, and he has a very good team. And I would like to use this opportunity also to remember Muele for all her commitment, our late colleague, and we will build on what her and the team in NTD has been doing. So thank you so much again, and the time to act now, based on your advice. So thank you. And Chair, back to you.
Thank you, Dr. Tedros. May I ask Dr. Sose to say a few words before we...
Just to say thank you. I think the chair and the DG have said everything we needed to hear. So I'm really glad to see the support provided by the DG. I'm not surprised. He's a real public health and humanitarian person. He cannot do something else, looking at NTDs and knowing exactly who is suffering from NTDs, and looking at the patient, the motivation and commitment we have from all of you. We can only, work hard to support you and to make sure that we continue protecting life and saving lives as WHO and as a global community. Thank you once again, DG, for your time and commitment and support. Thank you.
Thank you.
WhatsApp.
So now we will continue with the session for today. I'm pleased to also introduce the chair, Professor EMK from Netherlands. EMK, we've known each other for many years. I've also seen her progress from her in her professional career over the years. Now a professor. Congratulations. But it's good to see the young grow whilst the old begin to exit. Yeah. So we should always plan that succession plan. Now, MK, please, you have the floor.
Thank you very much, Kingsley, for those words, for making me feel a bit younger or older again. I'm slightly confused. I think we had a very impressive morning, and it's a bit difficult to now switch our heads and return to the session, but yet we will. It's the final session, and we do have a challenge time-wise, and we'll have to take care of that since some of you may need to go to the airport as it's the final day. So I'll be chairing rigorously. I'll get the hammer, and I have a second tool, which is that I'm from the Netherlands, and you know, Dutch people are known to be really rude. So the rudeness is the second tool. So I hope, but the reason is that, you know, we don't want people to miss planes, so it's not meant to be too offensive. So please, as speakers, try to be aware of the time so that we do have some time for discussions at the end of this session, as the discussions are usually really a very good part. So then I would like to give the floor to Gail Davey, who is going to update us on the critical needs in operational research.
Many thanks indeed, Inke. So good morning to everybody in the hall, and welcome also to those joining from all over the world. I'm obviously deeply honoured to be in the position of speaking at a session just attended by the Director General, and obviously at an event he has so warmly endorsed. My thanks also go to Dr. Kingsley and team, for whom this meeting is a genuine landmark after at least 5 years advocating the skin NTD grouping. So my name is Gail Davey, and I'm Professor of Global Health Epidemiology based at Brighton and Sussex Medical School. I also hold an honorary chair at Addis Ababa University. I have one conflict of interest to declare. My academic career over the past 20 years has focused on podoconiosis, the tropical lymphedema, just mentioned as one of the less familiar neglected tropical diseases. I founded and direct Footwork, the International Podoconiosis Initiative. So while I'll endeavour to keep this presentation free of bias, please bear with me if the word podoconiosis occasionally slips out. Over the next 15 minutes, there is no way that I could list all skin NTD operational research gaps in a way helpful to any part of this audience, whether academic, policymaker, programme manager, or patient advocate. So rather, what I intend to do is reflect on the process by which we may identify these gaps. As we draw towards the end of this 5-day meeting, it also seems appropriate to make some suggestions for future meetings. So first of all, what is the context of all operational research on NTDs? To account for the fundamental shifts of the roadmap, the traditional areas of operational research, service delivery, integration, mainstreaming, coordination, capacity strengthening must be extended, so structural issues like identifying enablers, clarifying stakeholder roles are included. This will ultimately help support progress towards universal health coverage and country ownership, as just mentioned by the Director General and Professor Hay. Next slide. So this is a context in which it's important to ask the question, what are the processes by which skin NTD operational research needs can be identified? What I'm going to do is introduce some of the systems that already exist at global and national level, and then make suggestions for the future. Next slide. So probably first and most obvious at global level is the Coalition for Operational Research on NTDs, which I'll from now refer to as COR. Next slide. As many of you know, COR hosts among other things, annual meetings, a series of Research Links webinars, the African Researcher Small Grants Programme, and a searchable database of institutions awarded funding to date. COR groups research priorities under the 5 areas indicated there: mapping strategies, diagnostics, programme implementation, stopping MDA and surveillance, and MMDP, also known as DMDI. COR has also supported work across priority areas, for example, that on visceral leishmaniasis across diagnostics and M&E. Much has been achieved in the years, go back please, of COR's NTD, COR's existence. However, there have been challenges in relation to equity of access to meetings, true collaboration across diseases, and there is a bit of a lack of One Health research there. So also repeating what has been a bit of a theme of this meeting so far, the focus on the 5 USAID Mass Drug Administration amenable neglected tropical diseases is ultimately to the detriment of these programs as well as the non-MDA neglected tropical disease programs. Next slide. The second global organisation I'd like to mention as a forum at which skin NTD operational research gaps can be identified is the NTD NGO network, also known as NNN. This has been mentioned before by Michelle. This current grouping of 88 non-government organisations attracts a wide range of implementers and country programme managers to its annual conference and to the webinars held between conferences. To me, the real power of NNN lies in 2 areas: its cross-cutting groups and its focus on the participation of affected people. Many of us have noticed that although skin NTD patients are present at this meeting, their voices have been relatively lacking. This is an important oversight, and I'm sure in future we will all commit to more meaningful involvement of people affected by skin NTDs at this meeting. Next slide. The cross-cutting groups ensure NNN alignment with the roadmap's focus on integration across NTDs. As Michelle mentioned earlier, there is one cross-cutting group specifically dedicated to skin NTDs. Workshops at the annual conference are designed to identify operational research gaps and also to disseminate among implementers the research conducted in response to these gaps. So these are 2 important global groupings that can act as conveners to help identify skin NTD research gaps. I'm next going to consider processes at national level that enable country-specific gaps to be identified and prioritised. Next. So I should start by saying I'm very grateful to members of the neglected tropical disease team at the Ethiopian Ministry of Health, and particularly Fikre Sefer, for discussions about their operational research process. In Ethiopia, the process starts within the technical working groups, which typically cover 2 neglected tropical diseases. These groups identify operational research gaps and then internally prioritise them. Each technical working group's priority list is then fed to the Cross-Neglected Tropical Disease Research Advisory Committee, whose members are predominantly academics. This committee then refines the research questions, makes onward introductions to appropriate research teams, and may also identify potential funding streams. You can imagine that this makes life for an external researcher like me very easy. When preparing a proposal, I can now contact the Research Advisory Committee and check whether their priority operational research questions fit with the area I'm planning to apply in. I don't know how many other countries' neglected tropical disease teams have anything similar in place, but as a researcher would thoroughly recommend developing a process like this. Next slide. Now I'm going to spend the rest of the time explaining in more detail the process behind a recently published article on research priorities to support the development of integrated national strategies to control skin NTDs. You can see the DOI there below at the right-hand corner. And there are several co-authors who I will acknowledge later, and some of them are in the room and others on Zoom today. So this process started in June 2021 with a COR Research Links webinar on Zoom, in which the presentations on each of these 4 areas were given, followed by breakout room discussions on challenges and research areas in those 4 bullet-pointed areas. Those discussions were collated and then used at a workshop within the COR annual meeting, which was held virtually 5 months later. At this workshop, the operational research gaps were shared and then ranked by participants using Easy Retro voting boards. I'm going to briefly highlight 2 of the areas that we explored as examples. Next slide. The first area was integrating MDA for skin NTDs. In the June webinar, Jean Bosco Mbonigaba presented the rationale behind integration of MDA for onchocerciasis, LF and scabies in Rwanda. And based on discussions arising from the presentation, challenges were identified in the breakout room and are listed there on the right. In the workshop 5 months later, the challenges were ranked, and then the operational research needed to address these challenges was identified and prioritised. Next slide. And you can see on the right-hand side of the screens the top 3 areas prioritised by this group, which were understanding community perspectives on integration, demonstrating cost-effectiveness, and addressing misconceptions and refusals around MDA. Next slide, please. So the second area that I'm going to use as an example is integration of skin NTD, disease management, disability and inclusion. In the June webinar, examples were given including the endpoint study of integrated care of podoconiosis, LF and leprosy in Ethiopia that we heard about on Monday. Also, there was a presentation on integrated screening and treatment of leprosy, yaws and Buruli ulcer in Liberia and Benin. The challenges listed on the right were then taken forward to the November workshop. Next slide. And during that workshop, the operational research needed to address these challenges was identified and prioritised. I won't read all of them out. Next slide, please. But they included mainstreaming of skin care and skin NDT, morbidity management and disability prevention into primary health care, identifying barriers to wash for people affected by skin NTDs, and, like for the first example, demonstrating the cost-effectiveness of integration. One thing that stands out about the operational research needs prioritised throughout the workshop, as indicated in the article we publish later, is how many of them require one or more of the social sciences, for example, anthropology, sociology, or health economics to be used. And I have to reflect that discontinuation of huge tranches of UK aid from the UK FCDO has severely impacted support of social science research in the neglected tropical diseases. So it is essential that we find new funders in this area. Next slide. I'm moving to a summary. So there are existing structures and groupings through which skin NTD research gaps may be identified. But going forward, we should consider this meeting as another potential forum, provided all relevant stakeholders able to attend. So I would put that as a note to the planners of the next of these meetings to include some forum in which these operational needs can be thoroughly discussed. Then on to countries. Some countries already have systems to identify skin NTD research gaps in place. And going forward, others should be supported to develop systems appropriate to their context. Thirdly, we've shown through the exercise I've just talked about that it's possible to conduct a skin NTD gap prioritising exercise. Though going forward, this needs to be replicated and adapted to specific situations. And finally, they're not on this table, I do want to come back to that preponderance of social science amenable gaps among the operational research gaps identified. Final slide. So as I conclude, I'd like to thank these individuals and institutions for their contributions to the COR workshop and to other discussions on how to identify and prioritise operational research in the skin NTDs. Once again, I want to thank Dr. Kingsley and team and all the organisers for this extraordinary 5-day meeting. We've all just been inspired by the Director General's presence, and we look forward to his ongoing support and encouragement as our global work in skin NTDs grows and evolves. Thank you very much.
Thank you very much for that talk. Please keep your questions for the end of this session. And I would like to give the word to the Fanzu au sujet de la prise en charge via les réseaux des églises.
Thank you very much. Thank you for giving me the floor. I am Delphé Fanzu. I'm a doctor and I work in DRC. And I work on combating skin NTDs. I have been doing so for at least 20 years. And here we're going to talk about an experience with holistic management of skin neglected tropical diseases through church networks in the Songolo territory. So that's the title of this presentation, Experience with Holistic Management of Skin Neglected Tropical Diseases through Church Networks in Songolo territory. That is part of a project that we called BCNC, Building Church Network Capacity to End NTDs. So, as an introduction, we all know that the objective of the 2023 framework for skin NTDs is to reduce morbidity and the psychosocial impacts of skin NTDs on discapacity. So for several years, we have been fighting skin NTDs while focusing on diagnostics and case treatments. So very little interest has carried on and taken into account psychosocial skin NTD aspects. So the collaboration now with churches and community institutions is crucial because they play a strategic role in terms of trust, and this in order to provide spiritual, physical support and spiritual support. So the objective of the study was to empower local faith networks and their leaders in order to provide these emotional and spiritual, this support and care to patients and families impacted by skin NTDs. More specifically, first we wanted to give faith networks the means to mobilize the religious community in order to identify the skin NTD cases and direct them to health services. And secondly, implement best practices and self-care among the community. And finally, provide ongoing spiritual and emotional support. In terms of methodology, this study was carried out between July 2020 and June 2021 in central Congo, in the Songolo territory, which includes two health areas, Kimsese and Sona Mpangu. This is divided into 20 areas of health. And in this study, we took into account 12 areas that were co-endemic, so 6 per area, which represents 30% of the health areas as they are compartmentalized in the territory of Songolo. There were 3 phases to this study. First of all, mapping and identifying the churches and the actors that needed training. In each church was the minister or pastor and 2 secular leaders. Then this next phase included the training that lasted 3 days, which we called BCNCE basic training, and finally the implementation as such of activities relating to the project. So for the basic training, which took place over 3 days, we started with the training on psycho-spiritual support of skin NTD patients. Second of all, we worked on the presentation of skin NTDs using tools that you see on the right-hand side here. We created some images that we collected and integrated into a tool. And we also had summary cards that are called 10 steps and that are a guide for health promotion and empowerment of people affected by NTDs. And on day 3, we worked on the communication and behavioral change, as well as information support on how to direct patients and how to report on a monthly basis. The results are the following. We identified 160 churches that were involved in the study. We trained 506 individuals, among whom we had 480 that came from the network of churches, 72 pastors or ministers, and 408 secular leaders. And we trained 26 health professionals on self-care. Here are a few images that were taken in the churches and in the Faith Network, during which we carried out the basic training, and the people who were trained were equipped in order to identify cases and on how to direct people.
Alors, en termes de nombre de personnes,
in terms of the number of people that we worked with during the time within the churches and within the community, we reached out to 25,702 people in the churches and 28,746 in the villages. And the number of suspected cases of skin NTDs was 441. And the number of presumed cases that came to the health center were 385, or 87%. So in the 441 suspected cases, we saw that Buruli ulcer represented 243 cases, and 25 of those were confirmed, 10% that is. 148 suspected cases of yours, with 2 cases confirmed, and we had 17 leprosy suspected cases, and 6 were confirmed. So within the churches, we were able to reconfirm the endemicity of 3 diseases, leprosy, Buruli, and yours. And in this period of 2020 to 2021, the cases at the churches were 17% for Buruli. The cases found through the churches network was 30% for yours, and for leprosy over that 2-year period, through the church network, we identified 55% of cases. So here we can see some images of patients who were identified through the churches network when it came to cases of Buruli ulcer. Often it was at an advanced stage, so there I could stress once more the recommendations that we heard yesterday, that in our countries there's a reduction in the number of cases, but if we relax and set aside our efforts, we're going to see an increase once more in cases. When it comes to the activities for self-management and self-care, we have a plan for the training of healthcare workers, and we identified that there were 38 people who could benefit from self-care. And of these, 32 benefited from training and the provision of the materials that are needed. So here we can see some images of the kits, and we followed Dr. Iber's presentation yesterday. So we have kits that we give to the patients for the management and treatment for a family in terms of self-care. So these are those who will benefit and have been selected because they'll benefit from self-care. When it comes to the psychospiritual support, with the suspected cases, the 441 skin NTD cases, we had 385 who were sent through to the healthcare structures. 81 of them benefited from spiritual support, and we also had cases that benefited and moved on further with it. So to conclude, our approach was successful. It allowed the local church networks to mobilize communities, raise awareness, identify cases, and direct people to the healthcare system. And it's the first time that in this area we were able to reconfirm the endemicity of yours. And we were also able to improve the case research and access to healthcare. We were able to provide a continuous spiritual and emotional support for those who needed it. We were able to reduce the isolation of those affected by skin NTDs and who were suffering from major stigma. And we were able to make people aware and give them the experience of the love of God amongst those who were affected by NTDs, and we were able to put into practice better practice for these groups. So our take-home messages and our perspectives for the future. The multidisciplinary approach is efficient, sustainable, inclusive, and really works towards providing an integrated mission. We strengthened the mutual trust through strong collaboration and communication in the field between healthcare providers, religious leaders, and patients. Patients and former patients committed to take on their own care after they'd learnt how to manage their disease and illness at home through self-care. We are planning now to increase this area of work and carrying out research to understand better quality of life and the psychosocial improvements from the point of view of patients. We're also progressively extending the coverage zone to other areas with endemicity. This work was multidisciplinary. We had doctors, nurses, physiotherapists, and many others involved. So here you can see a photograph of the training on self-care. And we would like to finish by thanking the American Leprosy Missions who have helped us with the implementation of our project, as well as the Churches Network and all the participants in the healthcare areas. Thank you.
Merci beaucoup.
Thank you very much. I'm very aware that there are many questions, but we will go to questions afterwards.
Juliana Amani Enegela on the barriers to care, accessing care in LF.
Greetings everyone present in the room and for other colleagues who are joining us online today. My name is Juliana Manyenegela, and I would like to thank Dr. Kingsley and his team for making this possible to, be at this platform to present the findings of this research on behalf of my co-authors. I am thrilled to be presenting this today, and the title of our research was on assessing the barriers associated with accessing LF mobility management and disability prevention services in Jigawa State, Nigeria. Next. This is the outline of the presentation: the introduction, study location, methods, results, take-home messages, conclusion, and acknowledgements. Next, please. It's been an exciting week of learning about the debilitating morbidities associated with skin NTDs, and lymphedema and hydrocele are clinical manifestations of lymphatic filariasis. They are skin NTDs that also requires morbidity management and disability prevention services. And I would like to mention here that morbidity management and disability prevention is a criteria for validation of the elimination of LF as a public health problem. And this is in addition to interruption of transmission through annual mass drug administration using albendazole and ivermectin. Next slide, please. So the expectation is while LF programs are being implemented, mobility management services should be integrated into the primary health care system. And the goal of our research is to access the barriers of accessing these services at the primary health care level in Jigawa State. The study was conducted in Nigeria, in one LGA in Jigawa State. LGA means local government area. Jigawa State is located in the northwestern part of Nigeria, and it has a population of over 5 million. It has 27 local government areas. We can also call them districts, and the research was conducted in one LGA, that is Birnin Kudu LGA in Jigawa State. The location for this research was purposely selected because a comprehensive NTD project was piloted in that location, and we believe MMDP services have been operational in the area for over 1 year. This research was an exploratory study. We conducted cross-sectional surveys. The 155 patients that were surveyed are patients that have benefited from the MMDP services or patients that have been identified to have either lymphedema and hydrocele. We conducted 6 in-depth interviews, and the participants were also lymphedema and hydrocele patients, and then we also had community and opinion leaders in the community and health workers. For the key informant interviews, the participants were the Director of Primary Healthcare Services at the state level, health workers, and the NTD coordinator at the state and the local government level. For the focus group discussion, we utilized the snowballing method to identify participants, and the category of participants are males, there are female participants with lymphedema, hydrocele patients, spouses of participants with either hydrocele or lymphedema, and male participants with lymphedema. We thought it was important to also do a rapid facility mapping to check for the availability of facilities in the research area, the functionality and capacity available in the facility. Functionality in this term was to check for, it was MMDP specific, we weren't looking at the functionality of the primary health system as a whole. We also checked for the services available, and we interacted with the staff to hear about the barriers for accessing MMDP services. We thought it was also important to check for partnership or collaboration between community actors and the health facility, and to also get an insight into recommendations on improving service delivery and utilization in the study area. So on the results, we had a total of 175 respondents, and our results shows that there's existence of primary healthcare facilities in the area where the research was conducted. We also looked at the records, and these health facilities had referred over 45 hydrocele patients to the secondary health facility, that's a district hospital. In Nigeria, we call it the General Hospital for services. However, we noticed that some of the health workers that were trained on MMDP had been transferred. So there was a need to retrain the health workers, and the resources or consumables were not available. The essential medicines and the consumables for MMDP services were not available. And from the interaction we had with the health workers, we realized that sometimes it was confusing for them to determine which cases should be managed at the primary healthcare level or should be referred to the secondary healthcare for management. So on the barriers, we noticed that financial constraint was the major barrier, over 50%, almost 50%. Lack of awareness was a second barrier, illiteracy, stigmatization, and we also, from the interaction, some of the respondents said there were no barriers. However, when we probed further, we noticed that illiteracy, the grouping on illiteracy and no barriers tend to be socio-cultural factors that were preventing, or were the barriers that were preventing them from accessing MMDP services. These are samples of the KRI's responses. The first sample is from a male respondent, and he was expressing fear that he would rather live with the hydrocele condition than go for surgery, because he feels that that area is a sensitive part of the body, and he thinks, going for the surgery would render him useless to his wife, children, and kinsmen. The second respondent below is a female respondent, and this just shows that a lot of women do not have access, direct access to get information about some of these services in the communities. In her words, she said, as a married woman, she only knows what her husband tells her, and this is applicable to all women in that community and in the context. Thank you. So to the take-home messages, we thought that awareness creation is very crucial, especially targeting women, because the research was the context of the research is a patriarchal society. So developing contextually appropriate messaging to ensure that it trickles down to everyone in the community, irrespective of gender, age, sex, or disability orientation. We also thought that it will be important to continue training health workers, irrespective of where they get transferred to, because understanding or having that knowledge or having knowledgeable people at the health facilities to provide MMDP services is important if we want to have it integrated within the healthcare system. We thought that innovative we thought that it would be important to adopt innovative approaches to identify cases and diagnose cases. We believe that would also increase access and utilization. In one of the morning sessions on Tuesday, we saw how digital tools were utilized to identify cases in resource-constrained settings, and we think it's something that we could potentially adopt and scale up in these areas. And safety and social stigmatization. A lot of people with skin NTDs and LF morbidities experience stigmatization and fear at different levels. And so it's important to continue to raise awareness and sensitize to change their perception of hydrocele surgeries. And again, that is at the level of the persons affected by these skin NTDs. But at the community level, I believe it's important to continue the community conversations. Well, I picked that term here this week from a presentation. The community conversations interventions would be important in changing the perceptions of community members on skin NTDs and LF morbidities. Next, please. So to conclude, we believe that scaling up the delivery of contextually appropriate communications and messages would increase the uptake of MMDP services in any LF program. I also think that developing inclusive, innovative approaches is critical for equality and equity in accessibility of MMDP services. The major barrier that we identified was transportation constraint. So we think that it's important to make services available in health facilities closest to the communities. And we also thought that intersectoral collaboration with other stakeholders for income-generating activities would also go a long way to improve the socioeconomic status of persons affected by skin NTDs. And then patients who have accessed services and have also experienced an improvement in their condition could be a very strong voice in the community to allay the fears surrounding hydrocele surgeries. Thank you. Next. So I'd like to thank all our survey participants. I'd like to thank CBM's implementation partner in Nigeria, HANDS, the Federal Ministry of Health and the State Ministry of Health Nigeria for providing an enabling environment for the research, and of course my colleagues Ismat Juma and Okpe Oguntoye for their support. I would also like to thank the director of the Eye Health Initiative at CBM, Dr. Baba Qureshi, for his continuous support to ensure that we eliminate NTDs in our supported countries. Thank you.
Thank you very much for the talk and for your very clear take-home messages. I would like to then introduce Laura Dean, who is going to talk about the person-centered approach in skin entities.
Do I need to? Okay. There we go. So thanks very much, everybody, for the opportunity to be here today, and I think it's been a fantastic week. I'm Laura Dean. I'm a social scientist by training, particularly in participatory and health systems research. I'm a lecturer based at Liverpool School of Tropical Medicine. And so I'm going to present to you today on behalf of the Redress Programme, which is a programme which is funded by the National Institute of Health Research in the UK. And many of our colleagues in the room, so Emerson, Carsaw and Julie, and many others online are instrumental in this work. So this really is a presentation on behalf of our partnership. So I think by the end of the week, we're all aware now that integrated management of skin NTDs is both a key political and programme priority. But we've maybe had less discussion this week on the central importance of people-centred health systems within this approach, and the central thread of empowering affected persons. But these are maybe all easy political and programme commitments to make, but we really need to think about how we implement this in practice. So what I'm going to talk to you about is the interdisciplinary development of an integrated case management strategy for specific skin NTDs in Liberia, which are endemic. And this is particularly related to onchocerciasis, yaws, hydrocele, lymphedema, and leprosy, and Bruley ulcer. And we think Liberia is one of the first countries to really operationalize such an integrated approach, and hopefully lots of useful learning will be presented to you today. So what you can see on the screen, hopefully, I know it's quite small, is the redress theory of change. And if we start at the centre, what you can see is that emphasised is that by working together across critical research domains, so clinical effectiveness and laboratory system strengthening, health financing, human resource management and patient engagement, but most critically putting affected persons and frontline health workers at the centre, we can work together to review existing approaches and also design new tools and methods for integration. And what we were particularly interested in was piloting these in Liberia. The underpinning methodology that we're talking about is participatory action research. And that means there's a series of key steps and processes which are reflected by the outcomes and outputs presented here. But we take time to reflect and work together at different points in an intervention to improve based on our challenges. Also central to this methodology is strengthening the capacity of national researchers and national research teams to provide ongoing support to national programmes, allowing them to deliver relevant and best practice science to strengthen the health system. So Redress's study design and our action sites are located in 3 counties in Liberia. These counties are selected based on match pairing to, number 1, inform the quality improvement in one county where integration had been happening in some elements, and number 2, to allow for scale-up of integrated approaches to new areas. So what does this look like in practice? Well, we begin with an initial reflection phase, and we have intense methods and participatory processes with stakeholders at all levels within the health system to identify their existing challenges and needs. So we worked with district health teams and facility staff, key informants across all levels of the health system, traditional and faith healers, people affected and other patient advocate groups to learn from their experiences, and also documented the views and experiences of community health workers. We then moved into a solution development phase. And critically important to this phase is making sure that a community advisory boards and affected persons were represented around the same table as Ministry of Health officials and policy decision makers. We established a Ministry of Health Technical Advisory Board to engage key stakeholders beyond the NTD programme, So thinking about laboratory system staff, mental health teams, community health teams, data management systems, etc. And so this solution development phase led us to 3 interconnected intervention pathways: case detection and diagnosis, enhanced human resource management, and the integration of mental health services and stigma reduction strategies. These are all presented within the Redress Intervention Manual in a way that's accessible to health systems, decision makers, as well as frontline health workers. And we've got lots of them with us today, so if it can be useful to you in electronic format for your programs or research studies, please do come and ask us. It's important that we share our resources, tools, and approaches. So don't worry that you can't read this slide. It's more of an illustrative example of the types of things you may find in the intervention manual. What you can see down the middle is a patient's journey from when they identified with skin NTD symptoms right to the kind of integrated, potentially tertiary level care, but also kind of support within the communities. What you see in red is how the tools in the intervention manual can support health workers or different actors at all different levels to support a patient on their journey through the health system and back to being integrated within the community. So what did we do in terms of case detection and referral? What you can see highlighted in red are the key inputs that we made within this intervention. And then at the bottom of the slide, you can see the many different process and output indicators that we use to monitor the impact. In terms of inputs, we provided training in terms of a simplified community skin algorithm to community health assistants, patient advocates, traditional and faith healers. We also trained health workers at facility level in the skin algorithm and standard management of NTDs. We tried to strengthen local laboratory systems, thinking beyond a strong referral facilities, but trying to use RDTs at the facility level and work with lab technicians in facilities to support them to take better samples, think more about storage and transportation of those samples. And we also tried to create better connection between the frontline elements of the health system and those a bit higher up to provide enhanced diagnostic supervision, communication, and feedback on the work that they were doing. Which leads us to our next slide, human resource management pathway, which is informed by Vroom's expectancy theory, which tells us that better supported health workers are more likely to be satisfied and more motivated to do the work that we're asking them to do, which is pretty obvious, but not always something that we prioritize. So what did we do in this area? We made sure that everybody who we were asking to engage in skin NTD services had a clear job description so they understood what they were supposed to do. We've tried to establish peer-to-peer supervision between community health surveillance supervisors so they can support community health volunteers in a more coherent way. We adapted training to move from a didactic approach to use more role play or scenario-based methodologies, which are essential for adult learning. We also encouraged more supportive supervision to allow for problem solving with health workers in ways that they wanted to solve their own problems. We made sure that community health assistants had the resources they needed to go out into communities and search for cases, and that might be simple things like a raincoat or rain boots so that they don't want to stop work during rainy season. And we also established a non-cash award scheme in health facilities to encourage them to look at their skin NTD data and think about what challenges they may make to their own solutions that may need to be different from health facility to health facility. Next slide. In terms of mental health and stigma integration, a lot of this work was informed by the work of the NNN Network, Disease Management, Disability and Inclusion, Mental Wellbeing and Stigma Working Group, and also links to the Essential Care Package, which is in development with WHO at the moment. But what we did was we tried to improve screening at facility level for common mental health conditions at the point of skin NTD diagnosis. This included screening using the PHQ-9 that's adapted for Liberia and the GAD-7. We also trained a cohort of mental health gap clinicians with adapted case studies for NTDs so that they could provide referral and talk therapy to those people who need it. At the community level, we focused on training community health assistants, people affected, and traditional and faith healers with the basic package of psychosocial support for NTDs produced by NLR and adapted for a Liberian context. We established a peer advocacy network and established peer support groups in different communities. You will have heard Hannah's presentation earlier in the week that emphasised our collaboration with traditional and faith healers, but critically working with them to think about how scripture and cultural-based advocacy can reduce stigma in communities. So this leads us to our implementation and action phase. At the bottom of the slide, you can see how the intervention began to roll out in June and will continue until September this year. At the top, you can see the research evaluation that is ongoing alongside this. We have many elements of a process evaluation which are informed by qualitative and participatory methodologies. We also monitor the DHIS2 data to see the impact. We're conducting a survey with affected persons that takes place at 3 different time points to understand our impact on mental health status and stigma reduction. And we also have a survey with the health workforce to understand how these new approaches can improve their motivation. You'll also see a critical mid-term intervention review and adaptation workshop to make sure we listen to health workers, understand their lived realities, and made adaptations to the intervention process. And we had that a couple of weeks ago. So far, Emerson, Castle and their team, I can take no credit for this, have trained 2,864 health workers and other types of individuals across our 3 counties. And so what are we beginning to see? We can see that there's been a growth in case detection across all of our conditions following the first 3 months of the intervention. There are huge challenges with the DHIS2 data, which we're trying to interrogate and validate further to understand why those challenges are happening. But initially, we think there's quite a lot of underreporting in terms of patients who are in facility ledgers, but then don't make it into the DHIS2 for many reasons. And so once we understand that further, we'll be able to do a more thorough quasi-experimental analysis and think about difference in difference to assess causality. In terms of our impact in training, and this is Kirkpatrick's training evaluation framework, what we can see in terms of reaction is that health workers now feel much more able to differentiate between different skin NTDs to make appropriate referral linkages or provide appropriate treatment. In terms of learning, we can see that there has been an increase in health worker knowledge reflected by difference in percentage points in pre and post testing. We can see the highest increase in knowledge amongst facility staff, particularly the OICs and second screeners represented in this slide. In terms of behaviour and results, we'll see more over the coming months and weeks. But what we can see initially is that mental health gap clinicians feel much more able now to engage with NTD-affected persons, and that peer advocates are on a path towards empowerment, feeling more able to support advocacy and stigma reduction in their own communities. In terms of our impact on people, on the left of this slide, you can see DeConte's journey, which was captured through some of our photo voice activities. And what it's showing is how, when implemented together, case detection, treatment, stigma reduction interventions can support to reduce distance between affected persons and their communities. I also wanted to present this quote to encourage us to critically reflect on the language we use when we talk about patients. Perhaps they'd prefer a more empowering terminology such as affected persons or survivors. It would be great to see us move towards that discourse in meetings like this, and looking forward to seeing more representation in the future, as Gail mentioned. In terms of our baseline mental health status findings, we can see that 24.1% of people affected experience symptoms related to generalized anxiety disorders, and that 42.7% are experiencing symptoms of major depression. There's no significant difference between the experiences of men and women, but really highlights that mental health is a critical thing that we need to continue to think about within this community. Next slide. So what are my concluding thoughts? I think that systems approaches are needed to truly address this complex problem of skin NTDs, particularly cross-department and sectoral collaboration, which is essential and possible in promoting innovation and mainstreaming and turning lots of the new ideas we've had today into today and this week into real-life things that we can see working within health systems. Participatory health research methodologies and planning approaches are central to this. They promote community engagement and ownership of programs on the road to integration and mainstreaming. And affected persons and often other unheard voices, including traditional healers, have the opportunity for meaningful and equitable participation when designing services and delivering them, and they might indeed unlock solutions to our ongoing challenges. And finally, I think accessible and adaptable tools and resources with clear training guidance are necessary to support the scale-up of NTD interventions, and I mean beyond clinical diagnosis, so thinking as well about human resource management and support, and also mental health integration. So thank you very much.
Thank you very much, and actually looking forward to hearing more at the next meeting. Then I would like to give the floor to Anne Schoenmaker on PEP for Lab skin cams.
Thank you very much, Inke. Okay, I will. And thank you all, also, of course, to all involved in the exceptional organization of this great meeting for the past few days. Yeah, there we go. My name is Anne Schoenmakers, and I'm working for NLR, an NGO focusing on leprosy. But today I'm standing on the shoulders of an entire consortium, and I'm presenting also on behalf of people from Ethiopia, Mozambique, Tanzania, Germany, and the Netherlands. PEP for Lab is a cluster randomized controlled trial in which integrated skin screening of leprosy contacts is combined with providing single-dose rifampicin as post-exposure prophylaxis for leprosy. In this trial, we have two interventions. One intervention is a community intervention, also called skin camps, in which around 100 close contacts of an index patient are being fully body screened, and they receive SDR PEP when eligible. The second intervention is an intervention in which household contacts are being screened at health centers. And community skin health events are bringing dermatological care closer to communities, and this is really needed. And I think other presenters also showed some of those great pictures from the article from Mosam and Todd on the shortages of dermatologists on the African continent. And what we see is that in Mozambique, for example, there are less than 20 dermatologists on a population of more than 31 million. And this is a real issue. In PEP for Lab, we organize skin camps with a broader health focus using the integrated skin screening approach. We don't only look for leprosy, but also for other skin NTDs and common skin diseases. The camps are organized in collaboration with community leaders, local organizations, community health workers, and community volunteers. And per skin camp, at least one dermatologist or experienced medical doctor or specialized nurse in dermatology is available. In the skin camps, there is no need for a leprosy index patient to share the disease status with the community. It is just announced that there is leprosy in the area. And like I said, around 100 contacts are being screened in 1 or 2 days. During the skin camps, besides SDR PEP for eligible contacts, we also provide free topical skin medications for those with skin diseases and also referral forms when conditions are more serious. So this is the PEP for Lab study flow. And in the skin camp group, we hope to include 270 index patients. and screen 27,000 contacts and providing SDR-PEP to those who are eligible, according to the WHO guidelines on leprosy chemoprophylaxis. The PEP for Lab study objectives are, we're looking at effectiveness, but also feasibility in terms of the cost effectiveness of this intervention and the acceptability of integrated skin screening, the use of NLR Skin app, and leprosy chemoprophylaxis. And in addition, we also measure the health workers' capacity. So I would like to share some preliminary results from the skin camps. Let's start with Ethiopia. In Ethiopia, up to now, 43 index patients have been included, and over 4,000 contacts have been screened. What we saw is that around 88% of the contacts were eligible to receive SDR-PEP, and there were no refusals. In the skin camps in Ethiopia, 33 new leprosy patients were found until December 2022, and 43% of the contacts screened were having other skin diseases than leprosy. And this is one of the pictures from the skin camps in Ethiopia. In Mozambique, 56 index patients have been included, and 26 skin camps have been organized. And what we see in Mozambique is that index patients are often living more closely together, being part of the same community, and therefore multiple index patients can be part of one skin camp. In Mozambique, 3,665 contacts have been screened, and as you can see, that is more than in Ethiopia per skin camp. Here, a lot of community contacts are visiting the skin camps, and people are living more closely together. Here, almost 90% of the contacts was eligible to receive SDR-PEP after full body screening. There were no refusals, and 72 new leprosy patients have been found, which is 2%, which is a very high percentage. In addition, 50% of the contacts screened had other skin diseases than leprosy. And this is one of the photos from Mozambique. As you can see, the skin camps are very popular, and a lot of community members are visiting them. In Tanzania, skin camps have been taking place since July 2020. They were the first country to start with the skin camps. They included 68 index patients and screened over 7,000 community contacts. Here we see that nearly 90% of the screened contacts were eligible to receive SDR-PEP according to the WHO global guidelines, and there were no refusals. 61 new leprosy patients have been found, and 55% of the contacts screened were having other skin disease than leprosy, so that's a very high percentage here as well. And on the photo on the left, you see Dr. Nelly Mageni. She is one of the dermatologists in this study and also doing a PhD on this project. And this is a photo of a skin camp in Tanzania, and here, for example, often school buildings are chosen for the skin camp organization, but sometimes also houses of community contacts or just a big tree where a skin camp is organized, the needs. So up to now, we have included over 50%, 55% of the targets that we have when looking at the sample size, and the project is still running, and we hope to include more index patients and community contacts until March 2024. As you can see, many skin diseases have been diagnosed during the skin camps, and these include leprosy, like I said, but also a lot of scabious patients have been detected, and also patients with other NTDs such as LF. But in addition, we saw a lot of skin diseases like acne or eczema and fungal diseases, and sometimes also diseases which could be linked to HIV/AIDS, and therefore those patients were referred also for further testing. And this is a really short video of a skin camp example in Mozambique.
Ashipapa aba afaromare no iwe
As you can see, it's pretty crowded, and crowd control is very important, as well as the logistical preparations to have it smoothly run and to screen all those people in just 1 or 2 days. We also started the acceptability study in January this year in Ethiopia, which includes surveys, interviews, group discussions, and observations. And what we noticed is that community members are very happy to visit the skin camps. Over 99% of the adults visiting the skin camp said that they would come again if another skin camp would be organized in the near future in their community. What we also saw is that leprosy chemoprophylaxis was a bigger incentive for people to visit the skin camps than the integrated skin screening and the free skin medication. And what we also heard from people is that PEP was really also used to destigmatize leprosy, as there was now more people knew that it was infectious disease for which antibiotics work. In addition, there seemed to be a positive effect on discrimination and stigma because of disease integration. One of the nurses said, for example, managing only the index case and the household members in this camp may expose the index case for stigma and discrimination. Integrated skin screening helps to keep the privacy of the index case and can also increase the confidence of the index case. Another nurse stated, this approach could increase the chance of getting hidden leprosy cases and also significantly reduce the discrimination against leprosy patients. So here I've listed the advantages of the PEP4Lab skin camps. What I really like in this project is that community health workers, volunteers, and community leaders are closely involved in the organizations of these events. They also really work as a motivation for the health staff, and it is a great opportunity for community education as well as on-the-job training. And the team in Ethiopia presented on the job training in dermatological care earlier this week. The combination with leprosy chemoprophylaxis seemed feasible, and no disclosure of the disease status is needed, which has a positive effect on stigma and discrimination, but we're currently further investigating the acceptability. There was a high turnout of community members, and many skin diseases were diagnosed. On average, now 50% of the contacts visiting a camp had skin disease. And for example, in Mozambique, we detected in only 4 skin camps 310 new gabius patients. And most of these patients were bystanders, so they were not even the targeted group of the 100 community contacts, but they still received dermatological assessments. Disease integration of the skin camp and skin conditions with other health campaigns, such as vaccination campaigns, may be useful for sustainability reasons. And all the materials, including the standard operating procedures on skin camp organizations, as well as the NLR skin games, which have been developed to train health workers, will be shared via Info NTD. And this is an example of the NLR skin games, which are an interactive health worker training tool on integrated skin screening. You can download them for free and also print them. And they've not only been used in the PEP4Lab countries, but for example, also in Nigeria, as you can see on the photo on the upper right. We also experienced some challenges. Of course, COVID-19 also heavily impacted our project. Physical distancing is a challenge when conducting community skin camps, so we had to pause the skin camps for a period of time. In addition, we see a high transfer of trained health workers, which was even worse during COVID, so often refresher trainings are needed. The inaccessibility of some areas is also a problem. In Mozambique, there are cyclones, which is a problem which is getting worse because of climate change. Some listed contacts were hard to reach, especially nomadic populations or internally displaced persons. There was a very high demand by the community on the skin medication, but of course our funding is limited. We're currently working on a cost-effectiveness study to also assess and share data on cost-effectiveness of these skin camps. And finally, what we noticed is that there are medication shortages. For leprosy, for example, rifampicin or also prednisolone in Mozambique, but also for scabies and tinea capitis. And I think this is really a human right issue, that there is no medication for skin diseases like the ones I just named. I think here, as this great skin NTD community, we really need to advocate together for medication for all. This is also part of the Sustainable Development Goals, and I think this is really, really important if we want to end NTDs in 2030. So more PEP for Lab results are expected soon and will also be shared via various platforms and open access peer-reviewed journals. And I would like to end with this take-home message from one of the heroes of this project, who also presented on Monday during this meeting. It is Biseo Beletta, and he is a tropical dermatology professional specialist in Ethiopia who participated in over 40 skin camps. He stated, "With the skin camps, you take the services nearer to the communities in need. There is no dermatologist helping the far or peripheral communities. If there are any dermatologists available, they are usually providing their services at the center in the cities. Skin camps are very important for our community because there is a high burden of dermatological diseases." So thank you very much. And if you would like more information on the PEP for Lab projects or on the skin games or in skin camps, do not hesitate to contact us. And you can also sign up for the PEP for Lab newsletter. And we would like to thank, of course, all patients, contacts, health workers, volunteers, and the community members in this project, as well as the funders. Thank you very much.
Thank you very much. Very impressive. We are now having our exercise. The questions will be at the end. And for the exercise, I would ask you all to stand up. Nothing more, since I think, to be fair, we've not been very good dancers over the past days, which may be because there was no music. So instead, as we are now standing, I realize there are many people in this room who take care of the people affected, but were not screened. So healthcare workers, people who go out to the communities, national programs. So I would like us, instead of rapport dancing, to give these people a very big applause. Then we move to the next presentation, and I would like to give the floor to Swapna Choudhury, and she will talk on self-help programs.
Thank you. Stephanie's not here, and this isn't working.
She's there. Oh, don't run. It's been a long week for you.
Sorry, it's not working. Thank you. If you go back to the first one. Yeah. Thank you to Dr. Kingsley and the team here for giving me the opportunity to present. My name is Swapna Choudhury, and I'm a research program manager at the University of Birmingham, and I work with Professor Richard Lilford on a grant funded by the NIHR, and it's looking at transforming the treatment and prevention of leprosy and Buruli ulcers in low and middle income countries. And today I'm going to talk about one of our 14 projects under this grant, and I'm looking at the sustainability of self-help programs in the context of leprosy and the work of leprosy missions. So today, sorry, Stephanie, I'm not sure whether you got the updated slides. Or... Okay, it's just let's carry on. Okay, so the WHO have published some guidelines for strengthening participation of persons affected by leprosy and leprosy services, and one of their recommendations is to establish self-help groups to help increase self-care practices and provide emotional support. So self-help groups tend to be based in the communities and involve the formation of groups of people with a common concern who can provide mutual support and form saving syndicates. So programs are promoted extensively through government and non-government organizations, and considerable resources are spent in LMICs on implementation of such programs to improve health and social integration and stimulate economic growth. Thank you. And again, thank you. However, little is known about the sustainability of such programs, and it's often not taken into consideration when planning. An evaluation of sustainability of these programs is therefore critical in determining how effective programs are in achieving their goals over the longer term period and whether activities continue once funding ends. So we are conducting a study. It's a multi-site study looking at the extent to which self-help programs activities continue in the time beyond the funding period, and also record any evidence of sustained benefits. And these are the sites we are working with. We are working in north-central Nigeria with Dr. Sunday and team with the leprosy mission there. Dr. Tony Mika in southeast Nigeria with the German leprosy mission. Dr. Joydeepa Dalong in India, as well as Dr. Indranapit in Nepal. So what we will be doing is retrieving and analysing documents, including any project reports and minutes, searching for evidence that self-help structures and processes have been sustained. We will also be conducting semi-structured interviews with two groups of people known as insiders and outsiders. So insiders are those people who were directly involved in the self-help programs during the funded periods, and outsiders are peripheral parties who are aware of the programs and who might have had evidence or information of the sustainability of the programs. And currently we're near completion in India and north-central Nigeria, and in the middle of data collection in southeast Nigeria and Nepal. And for analysis, we will be using thematic analysis, Braun and Clark's method, where we will code the transcripts and look for emerging themes. So what are our preliminary findings? So some of the benefits of joining self-help groups is that there's increased self-esteem. It also leads to empowerment, stigma reduction, provides a means of livelihood, improved housing, access to treatments, and it also gives them more access to state governments and can lead to entrepreneurships where people have gone on to build up their own small businesses. Some of the barriers to joining self-help groups is that there are doubts about objectives of why the self-help groups have been established in the first place. There's misconceptions, there's expectation that they will continue receiving funding rather than becoming self-sustainable and funding from funding organizations or the leprosy missions. Some of the factors of sustainability, good leadership and having a literate leader, people taking ownership of their ownership of the group, feeling that they are part of a family rather than just a group, that they have a joint decision-making experience, so they are heard in the groups that they attend, and they're not just told to do things. And then when there's loans available to people, that there's a flexibility of paying the loans back to them. Some of the barriers of sustainability are that there's been disputes among the members. There's people who have moved away from the groups, people who have moved away from the group areas for work. Also, marriage seems to be a barrier that people are trained, and when a lot of women marry off into another village, so they no longer can participate in the groups. Death of members is also a reason why groups aren't sustained. There's also a lack of awareness or poor knowledge about the availability of different opportunities, benefits, assistance, and also regarding what the actual self-help program was set out for. And also lack of skills to maintain equipment from self-help groups. For example, in Nigeria, north central Nigeria, they accessed some funds and bought some bikes. However, over time, they didn't know how to look after the bikes and ended up having to, the bikes didn't work and had to find other means of livelihood. So this is all in line with a review that we've done, and I'm sorry the slides aren't here for it, but I'll just talk about it. So we actually did a scoping review where we systematically searched PubMed, Web of Science, EconLit, and Google Scholar for peer-reviewed studies on self-help groups. And we included studies if they focused on self-help groups or primarily reported on a health program, a clinical intervention, or implementation. We excluded any articles that focused exclusively on microfinance or microcredit or on self-help programs for individuals only and not groups. And through this systematic scoping review, we identified 6,116 articles. After removing 637 duplicates, we screened the abstracts of 71 articles and found that 15 articles met our inclusion criteria for full review. 11 articles were from India, 3 from Africa, and 1 from Nepal. Only 6 of these 15 articles provided some evidence of or discussed a plan or steps towards sustainability, and only 1 of these 6 actually just focused on sustainability. And in this particular study, which was from Nepal, Sondal and team said that 80% of the groups were still active after 12 to 17 months after support was withdrawn. So in line with our findings from our research currently, what we found in the literature as well was that groups were more likely to be sustained if there was local importance. Members continued to acquire new knowledge through the self-help groups they attended. So there was a lot of information about maternal health and maternal care and newborns, and people felt that if they'd had their babies and they weren't planning on having any more babies, then the information they were getting was a bit redundant, so they needed new information from the self-help groups. They also thought that groups would sustain if people took ownership of the groups, which was common with our findings so far, and also that if people had a strong belief in why they were meeting and the importance of actually keeping going. The presence of a champion or a facilitator, volunteer, or a mentor from a group, from the organizing group, was also really important to ensure that groups continued and there was some accountability there. Groups were also more likely to be sustained if there was a unifying activity such as contributing to a fund regularly. And then groups were also likely to continue if the programs were done through an organization that had a long-standing within the community and had a good reputation. And some of the limitations of the included articles was that there was limited description of the intervention in this, of the interventions. Most of the self-help groups focused on health outcomes resulting from implementation rather than talking about longer-term sustainability. And the majority of studies reported results from programs that had evolved from an initial self-help program without discussing approaches to sustainability. So what we propose is that when people are planning and funding these programs to help the community, that some money is left aside or some plans are put in place to talk about how the programs are sustained once the initial program funding is complete. And with that, I'd like to thank you, the NIHR for funding this study, and also our collaborators at the Leprosy Mission Nepal, Leprosy Mission Nigeria, the Leprosy Mission India, the German Leprosy Mission, as well as the Leprosy Mission in England and Wales. Thank you.
Thank you very much. And now I would like to move to Daniel Ochera, who is going to update us on the community understanding of BU leprosy in Yo.
Thank you. Good morning. My name is Daniel Ochre, and I'm an MPhil student in public health studying health systems, policy, and management. On behalf of a very large team, I'll be taking you through some community understandings of the etiology of leprosy, Buruli ulcer, and Yos disease in the Achumamponia district of the Ashanti region. The SHARP project is a collaborative intervening research between the London School of Hygiene, Tropical Medicine and Hygiene, Noguchi Memorial Institute for Medical Research, Kumasi Center for Collaborative Research, and Amar Hansen Research Institute and Addis Ababa University in Ethiopia. And the main objective of this project is to improve outcomes for people living with skin NTDs. Skin NTDs are major causes of morbidity in Sub-Saharan Africa. Although treatable, they are associated with disability, stigma, especially when they are treated late. Negative assumptions about the causality also result in social exclusion of individuals and their close relations. Skin NTD is one of the topmost health problems with catastrophic effects affecting the people of Achumamponia. Now, the objective of this study is to highlight how affected people understand and experience skin NTDs or other common skin conditions, and to gain insights on how stigma is produced, experienced by different populations. Finally, we were in to look at how the physical rehabilitation produces stigma against patients or otherwise. We employed a qualitative approach by purposively sampling respondents through the hospital records, and then we followed up with Snowball, which led us to the traditional healer setting where we recruited the rest of the participants for this study. In all, there were about 68 in-depth interviews with both health workers and then all affected people and then non-infected people. 6 focus group discussions still between the non-infected and then the infected. And then we also conducted ethnography observation at the traditional healer setting, the health facility, and then the homes of affected patients. The audios were transcribed and analyzed using MassQDA, employing a 3-level coding structure to extract the main and sub-themes. And the picture we see is the focus group discussion going on with people living with the condition. By way of results, we found out that respondents attributed the causes to 2 main streams, the natural and the supernatural. Respondents believe it to be caused by some chemicals in the environment, and this is evident in the following quote. According to our own investigation, these skin diseases became common when galamsey started in this community. There were no skin diseases in the past. I believe the chemicals they use drain into the water bodies and causes skin diseases. Respondents also attributed the cause to organisms in the environment, and the use of skin creams. For example, a participant mentioned that it affects females more because they use creams that bleach their skin. So a little scratch on their skin leads to the disease. As I mentioned, others attributed the causation to supernatural. A young female living with the condition recounted that, "My pastor told me that someone had transformed into an animal and was biting my wound. He asked if I had ever had a dream about an animal biting me. When I told him I can't recall, he insisted that I've been bitten by a supernatural animal." It was also evident that sociocultural beliefs associated with the disease etiologies, one way or the other, influenced treatment-seeking options for patients. For example, in the above quote, this person living with the condition had tried his luck at the faith healer and ended up spending over 2,500 Ghana cedis hoping to get healed. And the picture on your right is a traditional healer introducing the field team to some of the herbs and the processes he uses when treating his patients. We found out that local understanding of the illness etiology promotes stigma, as stated in the quote below from a female during a focus group discussion. Let's assume a person used to send someone's child on an errand. By the moment the person gets the disease, that's borreliosis or any other scary skin disease, parents in the community start saying that the person had the disease because of witchcraft, hence restricting their children from running errands for the patient. And this is also a picture of a field team with one of the patients who insisted to have a photo with us because she believed one day she will appear on TV somewhere. Unfortunately for us, she passed on a few weeks ago from her condition. We also encountered some challenges, and all of them, there's nothing we can do about it. The first one is the deplorable nature of the road. The communities were very wide apart, and the shortest or the closest community can take you about 45 minutes on a dry day. We also have to cross rivers to reach the hard-to-reach communities in order to interview our participants. And the last image shows us trying or struggling with internet connectivity. Whilst passing through this community, we realize they have a spot where you can stand, and within a few minutes, you get some internet connectivity for your communications. I'd like to conclude by saying that the misconceptions and divergent views on the causes and modes of transmission among the study participants influence their care seeking. Patients who perceive the condition to be spiritually associated will seek care from faith healers, while those who do not see the condition to be that will visit the traditional herbal person or the biomedical center. We therefore recommend that awareness will be intensified on the causes, modes of transmission, and prevention of skin NTDs in the Achumamponia to reduce the negative experiences associated with them, as well as to improve patient treatment-seeking behaviors and outcomes. The picture here is a participant who had visited a traditional healer and gotten healed and was ready to go to the farm when we visited him. A few weeks of encouragement and education from field team to a school pupil or to the whole school, this former BU patient was seen playing with his friends when we visited. And you could see clearly that stigma is not present here. I believe it's because of our education we give them when we visited. So the take-home message I would like to say is that true knowledge dispels ignorance. So let's come together and let's invest in skin NTDs. I'm happy to acknowledge the following: our founder, the NHICHR, the director of Noguchi, Professor Dorothy Yeboah Menu, the whole of the SHARP team members, all the individuals and community members who participated in this study. I'd like to say thank you to everyone for listening.
Thank you very much for the presentation. I think it's very helpful to learn from the community members and their ideas on the disease. But we now move to money, actually, for the final two presentations. And the first presentation is from Edward Zijlstra, who is going to update us on the cost of mycetoma drug development.
Thank you very much. In this presentation, I would like to make a contribution to NTD pharmacoeconomics by discussing the cost of mycetoma drug development. In 2001, this report was published, which talked about a fatal imbalance, meaning, in fact, that during the time period between 1975 and 1999, only 1.1% of the almost 1,400 new drugs that were for neglected diseases, that represent, in fact, 12% of the global disease burden. And in another study that was published some years later, the situation hadn't changed much. Only 4% of 850 new therapeutic products registered were for neglected diseases. 1% of 336 NCEs approved, and 1% of 150,000 trials registered in 2011 were for neglected diseases. The NDI aims to discover, develop, accelerate access to urgently needed treatments for neglected patients, while focusing on gaps for infectious diseases that fuel cycles of poverty and disease in resource-constrained settings. And we do this in partnership with almost 200 partner institutions across the globe that are partners that focus on diagnostics, access, networks in endemic countries, major pharmaceutical partners, and academic and public health research institutes. Mycetoma is a typical example of an extremely neglected disease. The facts are that for the fungal type of mycetoma, called eumycetoma, there's only a 40% estimated cure rate with the currently existing treatments. While the disease is reported from more than 100 countries, but the actual global burden is unknown. So the challenges are very clear. The drugs that we have are ineffective, toxic, and unaffordable, and the current treatments for eumycetoma actually lead to low cure rates and high recurrence rates, and these recurrences all too often end in limb amputation. So we have completed the world's first and only randomized comparative clinical trial for mycetoma, together with our partners, to work on a safe and effective and affordable treatment. And the long-term goals is to prevent devastating amputation and disability and develop a safe, effective, affordable treatment to be used in rural areas and to ensure that people have access to that treatment. This is the map of mycetoma. The darker it gets, the more cases have been reported in the literature. And on the left part of the slide, you see Mexico, which has a lot of actinomycetoma, which is in fact the bacterial type of mycetoma. Then in Africa, Senegal and Sudan, and then further to the east, India. These are the areas where most cases have been reported from. So the treatment challenges are very clear. I think there's no need to try to read and understand this table. The message is basically that this overview of treatments available are based on cases and case series. There are no randomized studies. So that leaves us with cure rates for actinomycetoma, in fact, quite reasonable, more than 90%, but for eumycetoma, it is not more than 40%. And we only have the azoles to choose from. There's quite a lot of experience with ketoconazole in the past, but it's banned by the FDA and the EMA because of its liver and adrenal toxicity. And that leaves us, in fact, with itraconazole as the only choice for most LMICs. But it may be expensive, and the patients often would have to buy the drug themselves. And it doesn't work too well. Our review of data available from Sudan, again, leads to a cure rate not more than 40%. And the other azoles, as voriconazole, posaconazole, isavuconazole, all have their limitations for use in LMICs. We have conducted a trial with a new azole, fosravuconazole. And the profile of this drug is that it is a broad-spectrum antifungal. It is effective against candidiasis, and it is registered in Japan for the indication onychomycosis, which is a treatment of maximum 3 months. It has a favorable profile in the sense that it has a long half-life. This drug was developed by the Eisai company in Japan in 1995, and since 2009, DNDi is in a partnership with Eisai, and the drug has been tried in Chagas disease. And in 2015, the drug was repurposed for use in eumycetoma. So in 2017, we have started the first ever double-blind randomized clinical trial to study this drug. There were 3 arms in this study. One arm was fosravuconazole 300 milligrams, administered once weekly. The second arm, fosravuconazole 200 milligrams, administered once weekly, and itraconazole 400 milligrams, administered daily. And the study was stopped in 2021, and recently we have received the clinical study report. And the next step is going to be registration of the drug in Sudan. Fosravuconazole has a favorable profile as compared to itraconazole. The in vitro activity, as determined by Wendy van der Sander's lab in Rotterdam, the Netherlands, is 60 times higher. The dosing is once a week, which might be favorable, rather than dosing twice per day. Absorption is not affected by diet, whereas for itraconazole, you preferably have to take this with, for example, a cola beverage to produce an acidic milieu in the stomach to promote absorption. And it is a weak inhibitor of CYP3A4 and less likely to have side effects. In this Gantt chart, I'd like to indicate some important milestones. The repurposing of the drug from the Chagas program to mycetoma was in 2015. But the most important milestone was, in fact, in 2016 when mycetoma was added to the WHO list of NTDs, which is very important because then donors might be able to fund your proposed research when you're on that list. Before we could start this study, we needed long-term toxicity studies because remember, onychomycosis is only 3 months of treatment and mycetoma is 12 months, and there were no toxicity data in humans, and this drug was going to be used in humans for the first time. That was done by our partners from Eisai, performing these long-term tox studies, and this was an in-kind contribution. Between the start of the study and where we are now, the clinical study report in 2023, around 7 million euros were spent on this study, and we expect to spend another 1 million euros to work towards registration in Sudan. So how does this compare with other trials that were done in DNDi? And this is a breakdown of the total project cost. As you see on the left upper part of the slide, the 7 million euros. And if we calculate cost per patient, which is the middle upper part of the slide, we use the adjusted direct R&D cost, which is the R&D cost minus the CMC, because CMC costs vary considerably across the studies that have been conducted. So these adjusted direct costs are 38,000 per patient, which fits well in the range that we have with other studies, as you see on the right upper part of the slide. So where does the money come from? Most funds came from the Jihad Fund from Japan, 1/3 from core funding, portfolio funding, Canton de Genève, and the Bill and Melinda Gates Foundation. What were the cost drivers and collaborations? The hurdles we anticipated, this was a highly complex study with low patient prevalence. It was a phase 2 study with strict inclusion criteria, and patients were mainly in remote, hard-to-reach areas. This was the first ever randomized clinical trial in mycetoma. Nobody had experience with that, but of course, we are very lucky that this study could be done at the Mycetoma Research Center in Sudan, which is a highly experienced site. During the study, we encountered problems with the COVID epidemic and political unrest in the country. Initial enrollment was slow, and the study had to be extended. There were 4 FTEs from DNDi and 22 from the MRC. And the MRC should be commended for its high engagement and commitment on financial matters with good quality of financial reporting and punctual delivery. So the global spend, as mentioned, was 7 million euros over 6 years, plus 1 million more coming towards registration. How does this compare with other studies that have been done in DNDi, the existing drugs without new formulation? In fact, mycetoma fits quite well within the cost of other studies indicated on the slide. Existing drugs with new formulations are on average somewhat more expensive, and the most expensive studies are in fact the new chemical entities, as indicated on the lower part of the slide. And all this data, by the way, can be found in this open access paper, as indicated on the slide. Additional post-registration costs are not included here, and access costs are also not included. And these investments vary widely from project to project. The patients are in LMICs, and certain costs in clinical trials are lower than in high-income countries. But the logistics and trial coordination can very well be more complex. And in addition, DNDi invests 5% of the overall expenditure in strengthening existing clinical research capacities. And the cost of attrition due to failure rates of each stage of development is not factored in. Attrition, as indicated on the lower part of the slide, is not relevant in existing drugs without new formulation, but becomes more relevant in existing drugs with new formulation, and is certainly an issue when new chemical entities are being studied, because there is a lot of attrition there, as many molecules do not make it until the end into a drug that can be given to a patient. So where does that leave us? How can we put these costs in perspective? So this study cost around 8 million, and it is challenging to compare this to the cost of not having a drug. And of course, there are many factors that contribute to this cost, and I think here a pharmacoeconomic study would be appropriate. And at least some of these factors are listed on the slide: the cost incurred by patients and family, the lengthy health-seeking pathway, they need to travel, loss of income, not able to work. You have seen the disability caused by mycetoma in Professor Vahal's presentation earlier this week. There is stigma, psychological impact, and other socioeconomic consequences. And then, of course, there are the costs incurred by health system and economies, the burden on the health system, late presentations means longer and intensive treatment, recurrences put patients back into the pool that needs to be treated, operations, prosthesis, physiotherapy, that all comes into the equation. So, in conclusion, 8 million seems a lot, but compared to the suffering of mycetoma patients, I think it's actually quite cheap. And with that, I'd like to acknowledge the donors to our program, and I'd like to thank you for your attention.
Thank you very much. Glad these milestones were achieved, and can only imagine how much work that was per milestone. Now we're going to move to Jacob Novignon on the economic burden of skin NTDs in Ghana and Ethiopia.
Thank you, Chair. I already feel the pressure of standing between everybody else and lunch, so I'll go straight into it. I'll be speaking on some of the economic burdens that we have observed in Ghana and Ethiopia that patients experiencing skin NTDs face. And I'm presenting this on behalf of the SHARP collaboration, a lot of whom are in the room at the moment, and others have joined us online. So in the past couple of days, we've heard quite a number of presentations, quite insightful evidence on innovations and ideas about how to improve treatments and diagnosis. Most of these basically leading us towards understanding supply-side barriers and how to remove those barriers to improve the experiences of patients. But we can't do without understanding the fact that there are also demand-side barriers. And this morning, the presentations that have been done so far have already showed that, in fact, several other factors limit the type of care that patients seek and what pathways they choose in seeking that care. And I want to add on to that evidence to say that there is indeed economic aspects to those demand-side barriers. We show evidence from Ghana and Ethiopia that these barriers are consistent across the countries and indeed across the different disease conditions that we explore. So the evidence we present is part of a multidisciplinary formative research work that was conducted to support the development of an integrated intervention strategy appropriate for the different local contexts. And this is part of the larger SHARP project. And the formative work was just to inform the development of the complex interventions. The economic aspect of that formative work spoke to patients and key informants, as well as households and communities to understand the experiences that patients face. And we had this in three main themes. The first theme was to understand the cost and burden that patients face in seeking care. The second theme was to understand the cost of simply experiencing the skin disease, not even seeking care before you seek care, and understand what kind of coping strategies that these patients use when they face the costs and economic burden. In terms of methods, we used individual interviews and focus group discussions that covers patients, individuals living with the disease, their caregivers, community members, community leaders, traditional healers, and health workers. The broad formative work, of course, covered the economic burden, as I mentioned earlier, disease discourse and experiences, as well as stigma. And I'll be sharing the evidence on the economic burden today. 2 districts in 2 countries. In Ghana, the focus was on the Achumamponia district, as my colleague Daniel mentioned earlier. In the Ashanti region of Ghana, we had about 57 individual interviews and 7 focus group discussions that we focused on for the economic analysis. In Ghana, the focus was on Bruli, ulcer, leprosy, and yaws. In Ethiopia, we sampled the Kalu districts in the South Wollo zone in Amhara region states, where we had 52 individual interviews, 20 focus group discussions, and 21 key informant interviews. The diseases of focus in Ethiopia was CL, cutaneous leishmaniasis, and leprosy. So by way of results, I'll present this in two main stages. First, I'll tell you about the cost of seeking care, and I'll break this into the cost that patients face, the cost that their households face, and what happens when they choose to seek healing from traditional healers or from traditional sources. And then I'll talk about some of the coping strategies that have been adopted. We do also, as I mentioned earlier, talk about the cost of simply experiencing the condition, which I would also go into. So let me start with the cost that individuals face when they decide to seek care. So we found evidence from both countries, actually, that there is substantial financial costs in care seeking. And this sometimes leads to delays in diagnosis or not adherence to treatments, or sometimes poor wound dressings and delayed treatment overall, because patients do not have what it takes to pay for the cost associated with seeking care. And this was consistent in both countries. But in Ethiopia, it was interesting to observe that there were additional costs because of the conditions that we were focusing on. So CL sometimes required patients to stay for a couple of days at the hospital, and patients had to travel a good distance to the hospitals to seek care. So they spend some time over there, and that brings costs related to accommodation, the food they consume, lab tests, and sometimes imaging that is required. So one member of the focus group discussion we had recounted this as follows. He says, if one person goes to Boru is the hospital where CL patients go for treatment. So if one person goes to Boru today for treatment, it could cost around 1,000 to 3,000 birr, which is between 18 to 55 US$. And that is just the medical treatments. And so if you add to these transportation and other things, and staying there for 3 to 4 days, the costs, that costs much money. And then beyond the patients, there were costs of seeking care that were borne by the household or household members. This usually has to do with individuals who accompany the patients to the hospitals or who support the patients in paying for the treatments. So this comes in the form of financial costs or opportunity costs in this regard. So the financial costs include transportation costs, paying for travels to the hospitals with the patients, and supporting the patients in paying for wound dressings and medicines. For the opportunity cost, people who accompany these patients would have to sacrifice their productive hours, so the time they are supposed to spend on their farms or their housework or some other productive activities. They sacrifice that to accompany the patients to the hospitals. And this sometimes becomes a burden to the household members. In Ghana, an adult woman who is a caregiver to a female patient recounts that if there is no food, the father will go and look for food whilst I remain in the house to take care of her. If there is no firewood, then I will quickly go and fetch some and come back, so I don't get the time to go to the farm as I used to earlier. In Ethiopia, we found that sometimes patients were accompanied by adult men, where the patients are females. And one caregiver recounted and said that we went twice for care seeking, and he, which is the husband, lost 2 days of farming activities because he had to accompany the patients to the facility to seek care. And then what we also found interesting, and this was quite consistent in both countries, was that whilst it's commonly known that patients seek care from traditional healers, the reason why they choose this pathway is not very clear. And Daniel did mention earlier that there are cultural beliefs that inform the choice of traditional healers as sometimes the first point of care. So why do they ignore the former healthcare system and go to the traditional healers? We did find that there is some economic reasoning behind this, and this was consistent in both countries. The pathways, how this works is also in 2 ways. One is that these traditional healers are closer to the patients, and so the huge cost that transportation sometimes brings onto the patients and the household is taken away. The second one is that, and the most important one, was that the traditional healers do have more flexible payment arrangements. Sometimes they allow patients to wait until they harvest their crops, they sell their crops, and they have money to pay them. So patients could receive treatments whilst they wait to make payments when they harvest. So that payment arrangement was quite flexible for them compared to the former healthcare system. And in Ghana, a male patient recounted this in one of the community engagements. He said, but with the hospital, when they even prescribe a medicine for you, how do you go and buy them? Because you don't have money. You don't have anyone to ask for money from. So that's why most people go there to the traditional healer. And a similar quote is found from the Ethiopian engagements as well. Obviously, and as I said, the experiencing just the skin disease also has cost implications, and this goes to the individuals who suffers the condition as well as the household who suffer the condition. And this mostly comes from hours of schooling that is lost or hours of work that is lost because they can't engage normally in the economic activities. So how have these households coped with the economic burden that they face? We've tried to structure this in three main ways: formal insurance, informal community support, and household resources. Some of these are commonly known, so I'm not going to spend much time on it. So I would start with the formal insurance. So in both Ghana and Ethiopia, there is public health insurance. In Ethiopia, there is a community-based health insurance, which is designed to provide some coverage for people who suffer from skin diseases. And patients with coverage or who have subscribed onto the scheme do use that to defray some of the costs that they face. But there are inefficiencies and challenges. For example, not everybody is subscribed to the scheme. In Ethiopia, the district that we studied, there is about 60% coverage. In Ghana, there is a little over 50% coverage, which means that there is a huge part of the population that is still not covered. That's number one. Number two, if patients visit the facility, even if they have coverage, and there are stockouts, there are wound care materials are not available, they are forced to buy these things themselves from their pockets, which brings back the burden onto the patient. So there are issues with even these former insurance coping strategy arrangements. There are traditional risk pooling arrangements as well in both countries. In Ghana, we have the community health committee arrangements or system where they try to provide some support to patients when they suffer some of these conditions. A similar situation exists in Ethiopia. There are other arrangements for patients like labor contributions where patients are not able to farm. They get other people in the community to support them do that. Or they sell their assets, or they borrow, or they reduce their consumption just to be able to take care of the burden that the disease or the condition brings onto them. Yeah, so if we put all of these together, we see a negative feedback loop where the skin NTDs pose substantial economic burden onto the patients. The economic burden restricts access to prompt and effective treatments, and that leads to prolonged negative physical and emotional experience, and that again feeds back into the substantial economic burden that is faced. So how do we then design interventions that reduce this impact? First is to look for interventions that reduce the economic burden of care seeking. We can do this by getting treatment closer to the patients, in which case we would have reduced the huge travel costs that patients face, and including accommodation and food in the case of Ethiopia, or just simply reduce the economic burden that experiencing the condition brings. For example, reducing the physical barrier, the pains that patients go through so that they're unable to engage in their regular economic activities, or reduce the non-physical barriers in the form of beliefs that people hold, which restricts their ability to engage in their regular economic or work activities, or even schooling activities for students. So in sum, we see that even though there were varying conditions in both countries and the settings were not the same, it was quite evident that the economic burden that is faced is consistent across both countries, and that was quite substantial for the patients, their families, and sometimes the communities at large. These economic perspectives have shaped the interventions that have now been developed to now look at how to decentralize care to the patients as close as possible to ensure that some of these economic burdens are reduced. Currently, the interventions have been developed, and the next steps would be to start implementation in the second quarter of 2023 in the selected districts in Ghana and in Ethiopia. On this note, I want to thank the participants, the individuals, community members who participated in this research and continue to do so because the SHARP project has not ended, and to the funders and all our collaborators in the room. Thank you.
Thank you very much. And thanks to the speakers. We are perfectly fine in time, and we have time for discussions. And I would like to start with a question we received online from Beth Moose, and she's also part of the WHO team on snakebite envenoming. And as these patients, depending on the snake, often have huge wounds and skin issues. From that background, she's asking if there were any barriers in the way to collaborate with the traditional healers and how to involve them in care. And I would like to know if Laura or Daniel maybe have an answer to that question.
Yeah, I can try. I think there was we spent a lot of time in the beginning of Redress building trusting relationships with traditional and faith healers in understanding the role they provide in care in a non-critical way. And we did that through a photo voice study. And we then spent time with them understanding how they would like to be involved and trying to provide education around where their role could be and where their role may need to change. And a lot of what we found was actually that they want to collaborate more with the formal health system, but we often put barriers up to that happening. They also wanted to be considered in some places as quite distinct, separate groups, with traditional healers in one group and faith healers and different types of faith healers in other groups. But in some of the counties, they were very happy to kind of collaborate across traditional and faith healers. So I would say, obviously, there are challenges in terms of managing the impact to traditional and faith healers on their economic livelihoods, and working with them in a trusting way so that you can come to a space that is agreeable to everyone. It is really important.
Thanks. Daniel?
Yes. Just as Lara said, we also had similar feedback from the traditional healers where they were most enthusiastic to receive such collaborations. But they also quickly made mention that whenever they even try referring a client from their end to the formal health sector, the patients are turned back because probably it will just, where are you coming from? The traditional healer. Then go back, let him finish what he's doing. But here is a person who has seen that what he's doing needs a higher level of medication. So I think the collaboration is there. They are ready to collaborate with us. And we've also shown them that we are ready to do the same with them, and that we only need the health facilities and then the workers in the health facilities to know how or where we are heading towards. We are all aiming at getting someone treated, not who did it first. So I think that is something we should all be looking at. Thank you.
Thank you very much. Questions from the floor? I start. Okay. Yes.
Thank you, Chair. I just have some comment on the keynote speaker, Professor Gale, on operational research. This is just to add some information, what's happening on operational research and how we can exploit the experience we have. Because especially when it comes to the operational research, TDR has been working on operational research, especially on TB for the last 20 years. And that has been also implemented in Ethiopia, if you remember. And there is what we call it the sorted program, which TDR is running on operational research. And we have done it also in Ethiopia for NTD, especially skin NTD and other NTDs. And what we did was actually we used the experience of TB, which in TB program, what they do is they extract an agenda of operational research in the strategic plan of TB, always. And the strategic plan can be the 5-year, and there is always operational research there. So partners and NGOs will follow those operational research agendas and implement them. The same also, I'm not sure how the ministry was involved. I have seen the name of the NTD coordinator, but we have developed nationally an operational research agenda for NTDs in Ethiopia. And I'm just going to ask Professor Gale, have you seen that the roadmap for operational research of NTD? Because most of those skin NTDs are included there. And next October, actually, we have like a knowledge transfer meeting for an operational research we have done on NTD, and it will be best to consider that. Thank you.
Yes, thanks very much, Wanda, again. That's very helpful that you've sort of elaborated further on the process. And I think the kind of beauty of the committee is that there's a continual update, whereas for a strategic framework, you know, there's a point at which it becomes fixed in time. So, you know, you need both. You need something written, but then you need the ability to flex and move with time after that. Thanks.
Hello, I'm Dr. Belen Dufitas from University of the Philippines, Manila. And I'm also with Philippine Leprosy Mission, which works with, closely with patient support groups and patients themselves. My question is actually regarding the speaker, Mr. Delphine. You talked about training church workers. I was just curious, what were the, how are they trained to explain leprosy that's mentioned in the gospel several times? How was this explained to the public or to patients in the current context? And what were the key messages that, that were generated or that were or maybe taught to them, which seemed to have the most impact in the reduction of the stigma of leprosy?
Thank you for the question. I think it's a very difficult question. And I wonder, Delphine, can you give a slightly short answer, as I think that might be difficult as well.
Merci beaucoup.
Thank you. Indeed, that is a complex question. But the pastors and religious leaders were trained on spiritual support, on how to help these patients. And most of the message revolved around the love of God. So in the situation that these patients were in, to help them not think that they are punished, that their disease is a punishment. And of course, that doesn't, I mean, this message isn't communicated in a single contact. You have to develop that, of course, while you develop a relationship with the patients. And it takes time for them to deal with their illness and life. Thank you.
Sorry. Thank you for the excellent presentations. 2 questions also for Professor Guile. I was wondering how this operational research is linked to real implementation. I was happy to see that in Dr. Laura's presentation. Because concerning your priorities, I noticed issues like cost effectiveness is one of them, but not a major one. But this could be one of the criteria in building business cases for implementation. So how do you do the connection between the operational research and issues like cost and things that are very important in building business models for implementation, cost-effective programs? How do we build that connection in the various research activities that you conduct? Maybe Laura could take the question to extend, programming from what you see in research to programming in a large scale. That was the first question, and then maybe the second question would be for Professor Delphin.
Laura first, please.
Okay.
Thank you. I'm sure Gail will have lots to add as well from more diverse experience than I have. I can talk about how we're managing that within the implementation studies I'm involved in, and what we're trying to do is cost the intervention elements that we have implemented through the implementation research, as well as costing some of the processes that lead to that kind of integrated, participatory, inclusively designed intervention as well. So you have the cost of what it takes to design an intervention in that way for a specific country context, as well as the costs of what it takes to implement the different components of that intervention, so that you can almost create a shopping list for a donor or a country program to say, we really want to focus on this particular part of an intervention and look at how much that would cost them to then implement, so they can advocate to their governments, they could advocate to their funders. And so I think that costing element is a critical part of everything we do in operational research, but also packaging that in a way that it doesn't just sit in an academic paper, but it is something useful and tangible to the programs and to the ministries, and I guess to the people in this room as well.
Thanks. I saw there was a question from the audience there I would like to accommodate. And then there's one question, and that will be the last question. Good.
Thank you, Madam Chair. My question is for Ms. Amini and Angelo. Do you know if the recommended minimum package of care for LF is available for all chronic patients in the area that you showed? Thank you.
Thank you very much for that question. In my presentation, I did mention that the reason why we selected the study area was because we had earlier piloted a comprehensive NTD project in that area. And part of what we did was to train health workers around those facilities and provide consumables to ensure that the minimum care package was available in those facilities. Thank you.
Thank you. Then there was one more question, and that is unfortunately the last question.
Thank you very much, Ms. Chair. My question is for Dr. Delphine Fanzou. D'abord, merci de cet exemple d'intégration.
Thank you for your example of integration into community integration. The question is, how did you ensure the sustainability of your action? You talked about 80% success, so was that the case?
Merci.
Thank you. The idea with these projects is to contribute to strengthening community participation. We have worked for a long time with the traditional community members, but we're finding more and more difficulty because they're asking for financial motivation to carry out their tasks. So with these projects, we looked at the fact that maybe with the church network, the pastors, the secular leaders would have more compassion in terms of the patients affected with skin NTDs. It's a theory, and we went there to build capacity. The idea wasn't to provide salaries. So we're carrying out an assessment and a qualitative study with focus groups of these projects. So we're asking questions at the level of the beneficiaries, the patients, but also to see what we get in terms of feedback from the pastors, and to see whether this new approach, where the pastors and secular members are being used as the community links, they're doing the same work of awareness raising, identifying cases and sending people to the healthcare centres, and they're providing psychosocial assistance. And so we'll see what results are coming out from that, and to see whether we can compare the religious and the classic methods.
Questions left in the room, but we don't have time for them because I really don't want to disappoint Kingsley in the time management. So I would like another applause for the speakers, and then I would like to add something else before giving back the word to Kingsley. So first for the speakers, please. And as I think if I give back the word to Kingsley, I may not get it back. So I thought maybe, as Kingsley said, we go back a long time, but that's the same thing for many people in the room here. And the way Kingsley and Stephanie organized this meeting, I'm sure you noticed it is very, very careful, but for them it's the standard care, and it's been like that for every meeting, so I would like an extra applaud for the two. Kingsley.
Thank you very much for the nice presentations on operational research. I think we have learned a lot, and we have seen what the social science and operational research can also bring into our work on skin NTDs. But looking through the presentations, I also want to ask everyone here, as a lesson, to try to illustrate your presentation with pictures, nice pictures that, I mean, I'm not in Ethiopia, but if you present something that you also show the context where you are presenting from, I think it makes the presentation look, in addition to being attractive, look very, very powerful. I hate to see presentations which are only text. It's very hard to take anything home. So it's just looking through all these presentations this morning. My message to everyone, don't write too much text. Even one picture can convey the story you want to tell. And try to incorporate good pictures into your presentation in order to make them interesting. This is for all of us. Now, we've come to the end of the morning session. Thank you all for being good students, because when we said DG will be here at 9, try to be here 8:30. I saw that almost everyone tried to make it. We have a bit of this, finalization this afternoon. It may go a bit longer than 1 hour I had envisaged, but we will not go more than 1.5 hours. So this should be the plan. I've asked all the chairs of the different sessions to make one slide presentation or verbal about the key points coming from their sessions. I've also asked all our colleagues from the regional offices to also make one slide presentation on their own take, whichever way is a free way, democratic way of talking about what they would like to do going forward in their regions and what support acts to everyone here. So this will be the order for this afternoon, and we will draft a quick agenda and share with all the presenters before 2 o'clock. Then after that, we'll take some words of wisdom from Professor Rodhay. As the chair for this final session, you know, when you are put as the final chair, it means that you are going to give us the takeaway, which is fine. And then I expect that if Dr. Sose will return, Daniel is also here. We want to hear a bit from all of you, from WHO point of view. We are all fighting NTDs together, beat NTDs. So how are we going to move forward? 2030 is 7 years from now. Time is moving fast. We need to also move a little bit faster. So some issues that may come up during this afternoon. So 90 minutes, but there will be coffee after that. And then those who are traveling tomorrow, you may have 2-3 hours to go and buy some chocolates. And a Swiss watch, you know, Swiss watch. If you want to, we know of Italian shoes. If you want good shoes, we say Italian shoes. If you want good watch, it's the Swiss watch. So if you are here, and also chocolate, for some reasons, I see Ghanaians buying chocolates from Switzerland, whereas Ghana is the second producer of cocoa. So these are some interesting situations we can never understand. Anyway, please let us be back before 2. Thank you all for your excellent participation. We would like to thank the interpreters. We will thank them at the end, but for their understanding and cooperation for us to go over time from time to time. Okay. See you this afternoon. Bye-bye.